Hey y'all, this is Mike Hughes. I'm an internal medicine resident at Baylor College of Medicine in Houston, and today the plan is to talk a little bit about the treatment of hypercalcemia. In doing so, we'll try and review some of the basic physiology of calcium regulation as well as we go along, but we're not going to spend a lot of time on the symptoms, causes of, or workup of hypercalcemia because those really deserve their own talk. So, hypercalcemia refers to elevated serum calcium concentration. It can be evaluated with either serum total calcium, corrected for albumin, or with an ionized calcium. The first thing you want to consider in your patient with hypercalcemia is whether and how acutely treatment is needed. In general, patients who are symptomatic should get treated. For those who are asymptomatic, the degree of hypercalcemia is what matters. So mild calcium elevations are anything less than a corrected calcium of 12 or ionized calcium of less than 2, and usually don't require urgent treatment. You can start your workup, such as removing or treating the underlying cause may be all that you need. Severe hypercalcemia is considered to be anything greater than 14 or greater than 3.5 ionized, and usually it warrants acute urgent management. And then moderate hypercalcemia fits in the middle. It's in between at 12 to 14 or 2 to 3.5 if you're looking at the ionized, and may not need acute intervention if the change is chronic or if the patient is asymptomatic. However, an acute change into this range often ends up being symptomatic and requiring acute treatment. Okay, let's move on. So here we have our calcium concentration. Our first step in treating the hypercalcemia is going to be isotonic IV fluids. So hypercalcemia can cause polyuria and result in dehydration. The dehydration has the potential to exacerbate the nephrotoxic effect of the hypercalcemia. So we use isotonic IV fluids to dilute the calcium, return lost intravascular volume, and to facilitate renal excretion of calcium. Okay, so our first step is isotonic IV fluids. In a patient without heart failure or another relative contraindication, we typically start at about 200 cc's an hour and titrate the fluids until we achieve a urine output of about 100 to 150 cc's an hour. With very mild hypercalcemia, these IV fluids may be sufficient, but typically further steps are needed. The next few options we have act specifically on bone. If you recall, the bone is essentially a storage depot for calcium in the body. There's a complex system regulating this storage that we should just review briefly. So osteoblasts sit in the periosteum and create the bone matrix. They deposit calcium and phosphate into the bone. Osteoclasts sit in little pits on the bone surface and reabsorb bone, a process which releases calcium and phosphate back into the serum. So, the second option we often reach for when treating hypercalcemia is calcitonin. Calcitonin is a hormone produced endogenously by the thyroid parafollicular cells in response to elevations in serum calcium concentration or to gastrin. Calcitonin directly inhibits the osteoclasts from resorbing bone. It also decreases renal reabsorption of calcium, leading to further excretion in the urine. Okay, so calcitonin. We can take advantage of these effects in hypercalcemia by administering salmon calcitonin exogenously, either subcutaneous or intramuscular, typically at a dose of 4 units per kilogram every 12 hours or so. It works very quickly, within a few hours, and it can sometimes be given more frequently if needed. It's a good idea to start the medication early on if you think the IV fluids will be insufficient on their own. The big caveat with calcitonin is that it stops working after a time. The phenomenon is known as tachyphylaxis, and it commonly shows up around the 48-hour mark. And now the third option we have are IV bisphosphonates. These medications absorb directly into the bone and are taken up by osteoclasts, blocking resorption. So we usually use either zoledronate or pamidronate, although there are some others. They have a larger effect than calcitonin, but can take several days to work. IV bisphosphonates can cause flu-like symptoms in about 30% of people with the first dose, so you should definitely warn your patient and be ready with some Tylenol. Osteonecrosis of the jaw and renal function are other important limiting factors in many patients. Need for dental work or potential for osteonecrosis have to be weighed against the severity of the calcium elevation. And typically the medications are not given to people with a creatinine clearance of less than 30. Okay, so there's actually another important site in the bone that we haven't talked about yet, but that can be targeted. The two cell types we talked about, osteoblasts and osteoclasts, interact in a number of ways, but an important one is through the rank receptor. The rank receptor sits on osteoblast progenitors and also on osteoclasts, while the molecule that activates it, rank ligand, comes from the osteoblasts. When activated by rank ligand, the rank receptor induces differentiation and activation of the osteoclasts. And so by inhibiting this process, bone resorption can also be reduced, again limiting calcium release into the serum. The medication that does this is called denosumab. It's a monoclonal antibody that competitively inhibits interaction of the rank receptor with rank ligand by binding to rank ligand. It's typically used in patients who have had insufficient response with bisphosphonates or are prevented from using bisphosphonates because their creatinine clearance is less than 30. Denosumab. So it's a subcutaneous injection and takes even longer to start working, about 4 to 10 days, but can last for several months. Along with bisphosphonates, it shares the risk for osteonecrosis. An important consideration is also the risk for overcorrection to hypocalcemia, as patients with a creatinine clearance less than 30, in whom the drug is often used, as I just mentioned, are actually at higher risk, and the drug does hang around for a long time. Okay, beyond these, there are a few other medications that can help treat hypercalcemia and are more useful in some more specific circumstances. So we'll review a few other ways calcium levels are regulated in the body as we go along. So here's our GI tract. Calcium is ingested and then absorbed from the duodenum and upper jejunum in a process that is positively influenced by calcitriol, which is the 125 hydroxy form of vitamin D. As well, if you recall, vitamin D3 or cholecalciferol is either ingested or synthesized in the skin after exposure to UVB radiation from sunlight. D3 is converted in the liver to 25-hydroxy vitamin D, and then subsequently in the kidney by 1-alpha hydroxylase to the calcitriol. The final conversion can also happen peripherally, specifically in the setting of lymphoma or of granulomatous diseases such as sarcoid or tuberculosis. Glucocorticoids can help or decrease this process, decreasing the amount of endogenous calcitriol produced and thereby decreasing the intestinal or absorption of calcium. It's therefore an important option to consider depending on the etiology of your hypercalcemia. Another important way calcium is regulated that we haven't mentioned is, of course, with PTH, or parathyroid hormone. PTH is released from the chief cells of the parathyroid gland and has several important actions on bone and on the kidneys that influence calcium. It directly stimulates bone remodeling through direct activation of the osteoblasts. And in the kidney, it stimulates calcium absorption in a couple of locations in the nephron, and then also increases the synthesis of 1-alpha hydroxylase, which in turn increases the production of calcitriol, like we already talked about. Serum calcium concentration closely regulates the release of PTH. So higher calcium concentration should decrease the amount of PTH released. Therefore, in situations where the parathyroid is driving the hypercalcemia, or is at least contributing to some degree, such as in renal disease, a calcium mimetic called cinacalcet can be given in addition to make the parathyroid think the calcium concentration is even higher than it is. This is not a medication that is typically given in the acute period while you're trying to get the calcium down, but can be an important part or component of the overall management of hypercalcemia. A final group of medications that are important to remember are loop diuretics. In the loop of Henle, they create an electrical gradient that promotes the excretion of calcium. They're not usually used in patients who can tolerate fluids, but in those who cannot, such as those with heart failure, they can be really helpful. And finally, of course, as a last resort, dialysis can be removed, or can be used just to remove the calcium directly. Okay, that's probably a little more than we needed to go through just to review treatment of hypercalcemia, but hopefully it was helpful to go through some of the mechanics of calcium regulation in the body. Anyway, to summarize, evaluate your patient for symptoms and the severity of calcium elevation to determine the acuity of your patient's need for treatment first. Then start with IV fluids and calcitonin right away, as they work very quickly. If you can't do IV fluids, could the patient maybe benefit from Lasix? Next, consider the patient's potential to receive IV bisphosphonates and or denosumab. They may need a dental or OMFS evaluation, so you'll want to be thinking about it early, even if you're not sure whether they'll need it, ultimately. Okay, and consider the etiology of your hypercalcemia and whether glucocorticoids or cinacalcet might also be indicated in specific circumstances. For example, if you're peripherally creating calcitriol or your hypercalcemia is PTH driven. And as a final last point, just don't forget to look through your patient's medications to see if anything they're taking could be contributing to or worsening the hypercalcemia. Okay, that's it. I hope you enjoyed.